All for joining us for our March Family Room webinar, How to Know When It's Time for Home Care. Welcome back to those who were with us last month, and a warm welcome to all the new faces joining us today. We're truly glad that you're here with us. Today's session is a research-backed guide designed to help you recognize the clinical and real-world indicators that often appear when someone is beginning to need a little extra support at home. These signs can be subtle, easy to overlook, and different for every family, which is why conversations like this matter. As we move through today's content, you may notice one or two things that resonate with your own experience or someone that you love. That doesn't automatically mean that it's time to get a caregiver involved, but if you do find yourself identifying with three or more of these indicators that we're about to discuss, that's usually a good sign that it may be time to continue this conversation with your local second family office or with our Always Family office for those of us joining us from Texas. Our goal today is simple: to give you clarity, confidence, and a better understanding of what these changes mean so that you can make an informed decision with peace of mind. We will be hosting a Q&A at the end of today's webinar, so if any questions come up for you along the way, please feel free to jot them down in the chat box. So my name is Priscilla Goldston, and I oversee customer support at our Central Maryland location, where I also serve as one of our certified senior advisors.
And I'm Summer Sigalski, another certified senior advisor at our Central Maryland location.
So knowing when it's time for home care is vital because the earliest signs of decline are almost always missed. And by the time a crisis happens, families have far fewer choices. Understanding these patterns early is what protects safety, preserves dignity, and keeps independence possible. ADLs are more than a checklist. They are clinical indicators used across healthcare, insurance, and long-term care planning to measure functional decline. When someone begins struggling with these tasks, it often signals underlying medical, cognitive, or neurological changes that families may not recognize. Bathing is usually the first ADL to decline, and it's one of the strongest predictors of future care needs. Difficulty here often reflects executive function decline. This is trouble sequencing steps, such as turning the water on, then adjusting the temperature, washing your body, and then rinsing the body. Balance and proprioception issues. This is where the brain's ability to sense body position, which increases fall risk dramatically in wet environments. Temperature dysregulation. This is common in aging adults, making showers either feel too cold or too hot, and that can lead to hygiene avoidance. Families often think someone is being stubborn when in reality, the brain and the body are struggling to coordinate a complex task. Dressing challenges are rarely about clothing. They're about fine motor decline, shoulder mobility loss, or cognitive processing delays. Difficulty with buttons or zippers can indicate early neuropathy. Wearing the same clothes repeatedly may reflect memory lapses or decision-making fatigue. Taking much longer to get dressed can be an early signal of cognitive impairment long before a formal diagnosis even occurs. Toileting issues are one of the most sensitive indicators of declining independence. And what families often don't realize, continence relies on muscle strength, nerve signaling, mobility, and timing. A breakdown in any one of these symptoms causes accidents. Rushing to the bathroom increases a fall risk, especially at night when vision and balance are compromised. Many older adults hide toileting issues out of embarrassment, so families may not notice until the situation does become urgent. Eating difficulties are not just about appetite. They can often reveal swallowing changes, known as dysphagia. That increases choking and aspiration risk. Cognitive decline that affects the ability to plan meals, recognize hunger cues, or remember to eat. Hand tremors or weakness that make using utensils very difficult to manage. Malnutrition, which accelerates muscle loss, it accelerates the increase for falls, and it can often worsen chronic conditions. This is often the ADL where families underestimate the seriousness of what is actually happening. Mobility is the ADL that's most closely tied to hospitalizations and long-term outcomes. Declines here often can reflect gait changes that predict fall risk months before a fall even occurs. Reduced transfer ability, bed to chair or chair to toilet, which is one of the strongest indicators that 24/7 care may soon be needed. Muscle atrophy from inactivity, which can happen in as little as 72 hours for older adults. Mobility decline is rarely about just getting older. It's usually a sign of underlying medical or neurological changes. ADL decline matters when these tasks become difficult. It's not just inconvenience, it's a clinical red flag. Safety risk increases sharply. Falls, hospitalizations, medication errors, dehydration, malnutrition. Dignity becomes impacted, and older adults will begin to withdraw because of it. That can be socially, they will hide their struggles or avoid even asking for help. Caregiver strain will begin to rise because of it. Family members often step in without even realizing how much responsibility they're even taking on. ADL decline is one of the most reliable indicators that it is time to bring in structured support, not because someone is failing, but because their body and brain are signaling that they need help. These everyday changes are often the first visible cracks in someone's functional independence. So when families see on the surface, it's usually just the symptom. What's underneath is almost always neurological, cognitive, or physiological decline. Unwashed hair or unchanged clothes is not about laziness. It's often a sign of executive dysfunction. This is where the brain is struggling to initiate sequences or complete multi-step tasks. It can also reflect sensory changes, the water feeling too cold, too hot, or it's just overwhelming, which this will cause avoidance. When grooming declines, it's one of the earliest predictors that someone is losing the ability to self-manage. Transfers require core strength, balance, and proprioception. 3 systems that decline subtly long before a fall even occurs. Difficulty here can indicate early muscle atrophy, vestibular changes, or joint instability. Clinicians consider transfer difficulty a major red flag because it does predict future hospitalization risk. Missing meals is rarely about appetite. It's often tied to cognitive decline, where someone forgets to eat, they can't plan a meal, or they're losing the ability to recognize their own hunger cues. And it can also signal swallowing changes or fine motor decline. That makes eating physically difficult. Over time, this leads to malnutrition, which will accelerate weakness, and it increases fall risk. Incontinence is a complex neurological event involving timing, nerve signaling, mobility, and muscle coordination. When any of these systems weaken, accidents increase, and many older adults hide this out of embarrassment. So by the time families are noticing, the decline has usually been happening for months, and incontinence is one of the strongest indicators that someone's independence is at risk. These small changes are actually clinical breadcrumbs early warning signs that the brain and the body are struggling. Families often normalize them, but professionals see them as the first indicators that safety, dignity, and long-term stability are at risk. Safety risks are one of the strongest predictors that a person can no longer self-manage at home. What families see as little accidents are often clinical warning signs that the brain, body, or both are struggling to keep up with the daily demands. A near fall is just as clinically significant as an actual fall, and it often signals gait changes that appear months before a major fall. Slowed reaction time, meaning the brain isn't processing balance corrections fast enough. Muscle atrophy from inactivity, which can begin only a few days of reduced movement. Professionals treat near falls as early indicators of hospitalization risk. This is when leaving appliances on is actually rarely about forgetfulness alone. It can actually reflect executive function decline, where the brain is losing the ability to complete multi-step tasks. It's reduced situational awareness, where that is a common early sign of cognitive impairment. Sensory changes, where someone doesn't notice the heat, they don't smell it properly, or the sound the way that they used to. Families often underestimate how dangerous this is. Kitchen fires are one of the top home safety risks for older adults. Medication mistakes are often the very first sign that someone is losing the ability to self-manage, and that can stem from memory lapses, forgetting doses, or double dosing, vision changes where they're misreading their labels or the color of the pills, fine motor decline. This can be difficulty opening the bottles or handling very small pills. Medication errors are a major driver of ER visits and preventable hospitalizations. Trouble navigating stairs or clutter can reflect more than just mobility issues. It can often indicate depth perception changes, which makes steps appear uneven or distorted. Peripheral vision loss, which increasing the chance of tripping. Reduced proprioception, meaning the brain isn't actually tracking where the body is in the space. Clutter becomes a hazard because the brain can't process obstacles quickly enough. Safety concerns almost never resolve on their own. They tend to escalate because the underlying causes, which cognitive decline, muscle loss, sensory changes, these progress quietly in the background. And when these risks appear, it's a strong signal that structured support is needed to prevent crisis level events. Cognitive and behavioral changes are often the earliest signs that someone is losing the ability to self-manage, but they're also the most commonly dismissed. Families tend to attribute these shifts to either stress or aging or even personality, when in reality, they often reflect neurological changes and they're happening beneath the surface. Forgetfulness becomes clinically significant when it interferes with routine tasks, and this can reflect short-term memory impairments where new information isn't being stored properly. Working memory decline, which is making it hard to hold multiple steps in the mind at once. Reduced processing speed, which makes everyday decisions feel overwhelming. And this is often the first sign that someone is losing the cognitive bandwidth needed to manage medications, finances, or safety. Confusion and wandering are not random behaviors. They are neurological events, and they often indicate disorientation to time or place where the brain can't anchor itself in the present moment. Impaired spatial awareness, making familiar environments feel unfamiliar. Fight or flight responses. This is triggered when the brain misinterprets surroundings as unsafe. Getting lost in familiar places really reflects a breakdown in the brain's navigation network, which includes memory, visual processing, and executive function. When someone is getting lost in a place they've known for years, it often means that the brain is struggling to form or retrieve mental maps. Visual cues can no longer trigger recognition. The person is relying on instinct rather than memory. This is a major red flag for early dementia and is often noticed long before a formal diagnosis. Difficulty following routines can often have someone sequencing attention and executive function. So when someone can't follow steps they've done for decades, like making coffee or paying bills, this is called executive dysfunction, where the brain can't organize or prioritize tasks. Cognitive fatigue, where mental energy drains very quickly. Loss of procedural memory, which is usually one of the last memory systems to decline. Families often interpret this as being forgetful, but clinically, it is a sign of a much deeper neurological change. Cognitive and behavioral changes rarely appear all at once. They will creep in gradually, but once they're noticeable, the underlying decline has usually been progressing for months to years prior. And these changes are some of the strongest indicators that someone is no longer safe without structured support, even if they appear physically healthy. Nutrition and household management are often the easiest or the earliest functional systems to break down. Long before mobility or medical symptoms become obvious, these changes reveal what's happening behind the scenes. Cognitive load, energy levels, executive function, and emotional bandwidth. So something like spoiled food, it's not just about forgetfulness. This can easily reflect executive function decline, where planning, rotating, and discarding food is becoming overwhelming. Reduced appetite cues. This is common in aging adults, and it can lead to less frequent fridge checks. Sensory changes, where smell and taste are weakening, making it harder to detect spoilage. Clinically, spoiled food is one of the earliest indicators that someone is struggling to manage daily nutrition safely. Missing meals points to a deeper issue than just not being hungry. This often will signal cognitive decline, where the brain is forgetting to initiate eating. Difficulty preparing food, especially when fine motor skills or sequencing are impaired. Fatigue or depression, which can suppress the appetite and the motivation to eat. Over time, missed meals lead to malnutrition, which accelerates weakness, confusion, and increases the risk for falls. Unopened mail is a classic sign of executive overload, and it easily reflects decision-making fatigue, where even the simplest tasks feel mentally very heavy. Anxiety or avoidance, especially when bills or paperwork feel confusing. Declining attention span, making it hard to sort, prioritize, or even follow through. Professionals will view unopened mail as a red flag for cognitive strain. Unpaid bills are rarely about money. They're about processing speed and task management. They indicate the working memory decline is making it hard to remember due dates. Difficulty navigating technologies such as online portals or automated systems. Loss of routine, where long-standing habits are beginning to break down. This is often one of the first signs families notice when someone is losing financial independence. Laundry buildup reflects more than physical fatigue. It often signals mobility challenges, making bending, lifting, or carrying laundry unsafe. Cognitive overload, where multi-step tasks become too complex. Reduced energy reserves. This is common in chronic illness or depression. Laundry decline is subtle, but it's a very powerful indicator that someone is struggling to maintain their environment. These household changes are early warning signals that someone is overwhelmed, physically, cognitively, or emotionally. They often appear months before more obvious safety risks, making them critical for every intervention and preventing crisis level declines. Emotional and social withdrawals are one of the most under-recognized early indicators that someone is struggling. Families often interpret these changes as moodiness, aging, or just being tired, but in reality, they often reflect deeper cognitive, neurological, or health-related shifts. Isolation is rarely a choice. It's usually a symptom, and it can signal cognitive fatigue, where social interactions become mentally overwhelming. Hearing loss, where this will increase withdrawal because conversations feel exhausting or embarrassing. Early dementia, where following conversations becomes difficult, and that can lead to avoidance. Isolation is strongly linked to accelerated cognitive decline and increased hospitalization risk. Loss of interest in hobbies. When someone stops engaging in activities they once loved, it often reflects executive function decline. This makes planning or initiating activities very difficult. Anhedonia, a clinical symptom where the brain no longer registers pleasure normally. Motor or sensory changes, making hobbies physically harder or less enjoyable. This shift is one of the earliest signs that someone's emotionally and cognitive reserves are diminishing. Depression and anxiety in older adults often look different than in younger people, and this may show up as irritability instead of sadness, withdrawal instead of worry, physical complaints instead of emotional expression. These emotional changes can be triggered by changes, chronic illness, medication interactions, or loss of independence. They are just as important to address as the physical symptoms. Emotional and social withdrawal often precede or accelerate physical decline. When someone disengages from life, you often see reduced mobility, poor nutrition, increased fall risk, faster cognitive decline. Emotional health is a core part of functional independence, and changes here are powerful early indicators that someone needs support. Caregiver burnout. This is a very important topic. Caregiver burnout isn't just an emotional experience. It is a clinical indicator that the care environment is no longer sustainable. Research consistently shows that when a caregiver begins to struggle, it directly predicts unmet care needs for the person receiving care. So in other words, burnout is not just about the caregiver's well-being, it's a measurable sign that the entire care system is under strain. Exhaustion in caregivers is more than just feeling tired. It reflects chronic sleep disruption, often from nighttime wandering, toileting needs, or anxiety about safety. Cognitive overload, where the caregiver is constantly anticipating risk or making rapid decisions. Physiological stress, which raises cortisol levels and weakens the immune system. When exhaustion appears, it often means the caregiver is functioning in survival mode, and the care recipient's needs are now exceeding what one person can safely manage. Irritability is a neurological response to prolonged stress, and it often signals decision fatigue, where the brain becomes overwhelmed by constant micro decisions. Emotional depletion, where empathy becomes harder to access because the caregiver is running on empty. Role strain, especially when the caregiver is balancing work, parenting, and caregiving simultaneously. This shift is one of the earliest signs that the caregiver's emotional bandwidth is collapsing. Feeling overwhelmed is a sign that the caregiver's executive function is being pushed beyond capacity. It often reflects task saturation, where the number of responsibilities exceeds the brain's ability to organize them. Loss of predictability, common when the care recipient's needs fluctuate day to day. Reduced resilience, where even small tasks feel fully unmanageable. This is a major predictor that the caregiver may unintentionally miss medications, appointments, or safety cues. Pain is one of the most measurable indicators of caregiver burnout, and it often includes musculoskeletal injuries from lifting, transferring, or supporting mobility, chronic pain, which reduces the caregiver's ability to provide safe physical assistance, fatigue-related coordination issues, increasing the risk of accidents for both caregiver and care recipient. When physical strain appears, it often means the care needs have surpassed what one person can safely provide without support. Caregiving is a two-person system. When one part of the system becomes unstable, the other becomes vulnerable. Burnout is not a personal failure. It is a clinical signal that the care plan needs reinforcement. Ignoring caregiver strain does increase the risk of falls, hospitalizations, medication errors, emotional withdrawal, crisis level decisions. Caregiver burnout is one of the strongest indicators that it is time to bring in structured support, not just for the caregiver's well-being, but for the safety and stability of the person receiving the care. The crisis curve is one of the most important concepts families need to understand because it explains why so many care decisions feel sudden, overwhelming, reactive. Most families don't realize that decline follows a predictable pattern and that the warning signs show up long before crisis itself. The pattern behind the crisis curve: decline rarely happens in a straight line. It happens in plateaus where someone seems stable, followed by a sudden drop triggered by stressors that the body can no longer compensate for. These drops are what families experience as the crisis, but clinically, the decline has been building for months or even years prior. Professionals see the crisis curve as a trajectory, not an event. Families often see only the event. A fall is never just a fall. It is usually the result of gait changes that began months earlier, muscle atrophy from reduced activity, balance and proprioception decline, medication interactions affecting alertness or blood pressure, environmental hazards that the brain can no longer process quickly. A fall is often the moment families realize something is wrong, but clinically, it is the outcome of a long period of unaddressed decline. Hospitalizations are major inflection points in the crisis curve, and these often reflect acute decompensation, where the body can no longer compensate for chronic conditions, infections, which cause sudden confusion or weakness in older adults, medication mismanagement, which is one of the top preventable causes of ER visits, functional decline, where the person can't safely return home without support. After a hospitalization, most older adults do not return to their previous baseline, even if the medical issue is resolved. This is why post-hospital care planning is so critical. What families call sudden is often the point where the body's reserves are depleted, and this can be triggered by dehydration or malnutrition, sleep disruption, cognitive overload, unmanaged chronic conditions, emotional stress or isolation. The decline feels abrupt, but the underlying systems have been weakened quietly in the background. Families often delay support because the decline is gradual and easy to normalize. The person has good days, masking the trajectory. Loved ones without really realizing how much they're even doing. There's fear, guilt, or uncertainty about bringing in help. They don't know what early signs actually even look like. By the time the crisis hits, the options are now very narrow. The stress is skyrocketing within the family, and the decisions must be made quickly. Early intervention changes the entire trajectory of the crisis curve. It stabilizes daily routines, it reduces fall and hospitalizations, it supports cognitive and emotional health. It protects the caregiver from burnout. It preserves independence for far longer. And this allows families to make thoughtful, proactive decisions instead of reactive ones. So the message here for families is very simple. You don't wait for the crisis to get help. You get help to prevent the crisis. And what I'm going to do now is pass this along to Summer, and she'll be able to discuss further how this can really look and support.
Absolutely. Thanks so much, Priscilla. And one of the most common and emotional questions that families ask myself and Priscilla is, how do I know when it's time? We are here to listen. We are here to give our advice, but under the understanding and guise that we know everyone's situation is different. Everyone's situation is unique, and we try to meet you where you are. But one thing that we can tell you is the time to reach out to a home care agency, the time to reach out to have these conversations is not when there's a crisis, not when it's too late, but when it's appropriate, supportive, and proactive. The families who call during the crisis always say the same thing later. We should have done this sooner. And that breaks my heart to hear, because we are here. We're here to help. And this is why we felt this topic was so important to share and discuss, because proactive care is the preferable approach over waiting for a crisis, especially in home care. Being proactive helps to decrease hospitalizations and reduce the risk for injury. Crisis care, in terms of being in a hospital and you're given some options for after discharge, or same thing with a subacute rehab facility, you're given some options of your plan for after discharge. A lot of times those options come right before the discharge occurs. So because of that, it can lead to reactive decisions, it can lead to limited options, and higher stress. So when it's time to start the conversation, if your gut is telling you that something has shifted, that's worth listening to. The need for care is typically indicated by a noticeable pattern, as Priscilla had mentioned, and it involves more than one issue rather than a single incident. So referring back to the crisis curve, early intervention is crucial to stabilize routines, reduce risk, and allow families to make thoughtful, proactive decisions instead of reactive ones. The question of when to seek care is so hard, it's so difficult, because people do not plan to need care. And the fear of losing independence is also a very prevalent reason as to why people don't reach out to us early enough. Adult children may also feel guilty or question the financial commitment involved. So as certified senior advisors, we see these types of situations every day. Families don't struggle because they don't care. So we want to make sure that that point is made prevalent. It's not that you don't care. We are not seeing that, if you come to us in a crisis situation, it's because you did something wrong. Not at all. Not at all. But if we can help you come to us sooner so that your loved one or yourself can receive care sooner, that's our purpose here. We understand that there's guilt. We understand that there may be denial. We understand that there might be a fear that, either yourself or, whomever is expressing these concerns, or if you're the one expressing the concerns to your loved one, that you may be overreacting, right? But again, if your gut is telling you something is off, follow it. Our role is to help bring you clarity in what can already feel like a very emotional and uncertain time. The biggest myth surrounding home care is the fear that it equates to a loss of independence. But in reality, home care helps preserve independence by encouraging clients to continue their day-to-day tasks independently per where they are in their journey. At Second Family, we don't step in to take over, we step in to support. So when our certified nursing assistants come in to help yourself or your loved one, they're coming in to help encourage yourself or your loved one with their activities of daily living and meet you where you are. And if we go back a little bit further to our registered nurse care plan and assessment, that is something that your registered nurse will talk with you about. What are you able to do? What do you need the most help with? And what can we encourage you or your loved one to continue on, even though it is challenging, so that our caregivers can thus have a better picture as to how they can step in to help and encourage and empower, as opposed to take over. And we see then a loss of the independence, a loss in the client's ability to do the tasks that they were once able to do independently. And we want to preserve dignity. So that's the main goal here. We're not stepping in to take over, we're stepping in to support. So some practical steps for beginning the conversation. I always suggest with starting with, I've noticed a few things and I just wanted to make sure you're safe. Not, you can't live alone anymore, or you need help, right? It's really about the language and your tone of voice, and your language and your tone really makes a difference in the success of that conversation. It's important to focus on being person-centered, not blaming, and leading with concern rather than control. So control and independence kind of go hand in hand, right? The client wants to maintain the control of their day-to-day life. They want to make sure that they're able to maintain their independence for being able to complete their day-to-day tasks in their reality that they're living in. What can be very stressful is if they feel that they are losing control. That's why we see clients tend to hide certain things, such as incontinence, as Priscilla had mentioned. Not only is it embarrassing, but it is a key indicator that control is starting to diminish, which is not what we want for our clients, not what we want for our clients' loved ones, right? We're here to meet you where you are. So these sensitive discussions should take place during a time of calm, if possible, and not during a crisis, right? We understand that crises can be unpredictable at times, they can happen, but the best time to have these conversations when we're looking to be proactive is to have them during a calm and comforting time, again, meeting them where they are, as home care should be presented as a support system and not a replacement. So our goal here at Second Family is to ensure families feel supported from the very first phone call, starting with a no pressure phone consultation to create a safe space to be able to discuss what you're seeing and your concerns. When you're ready to move forward, a free in-home assessment is conducted by a registered nurse who creates a customized care plan. We are always willing to work with families on introducing caregivers as early in the care journey as possible to build trust. We don't believe in one-size-fits-all care and know that each person in need of care is coming to us with different needs. It is our mission to ensure that each client feels seen and heard, and we meet them where they are with safety and high-quality care. One of the last and one of the most important messages that we want to portray here in our webinar is that you are not alone. Myself, I have been impacted by care needs in both situations of crisis and in being proactive. Either way, it is hard. And I know Priscilla has been in that role as well, personally, not just professionally. We talk to families every day and we understand, but we've also been there personally. So our hope is that families, you leave here today feeling empowered, or if you are the care recipient yourself, that you leave today feeling empowered and not pressured. Our role is to guide, educate, and advocate. And our responsibility is to ensure that when that time comes and you want to start the process and go on your care journey with us, that you have a trusted team ready. If you feel that you or a loved one resonate with more than at least 3 of these points, please know it is okay to reach out. We will also be sending over a survey in addition to our thank you email that we send out after our webinar. And this survey includes check boxes to help you understand, again, the key indicators that we went over in this webinar, and if home care is right for you in this current moment. So please keep a lookout, but again, know that we are here in the meantime. So we wanted to include the research sources. A lot of both of our content is, and I shouldn't say a lot, all of our content is research-based and backed by these references here.
Yes.
So we just want to leave this up so that you guys can see where we retrieved our information from.
Yeah, the whole webinar was evidence-based from those sources, not just from those sources, but from Summer and I's educational experience and becoming certified senior advisors as well.
Yep. Well, everyone, thank you so much for joining us here today in our family room. We want this, again, to be a safe and comfortable space for you to feel valued, appreciated, and heard. So please, at this point, take some time. If you have some questions, go into the chat box and write out your questions, and we will answer them in the order that we have received them. But in the meantime, we wanted to let you know, as an announcement, our next month's webinar will be a great topic and a very important topic. So it'll be on April the 9th, and it'll be regarding understanding hospice, palliative care, and home care. And a who does what kind of situation. Because we can understand, again, when we are starting to talk about hospice care, palliative care, and what each person's roles are, right? It can get a little daunting, it can get a little confusing. So we're going to have Lindsay Roby with Stella Maris. We've partnered with Stella Maris at our Central Maryland location for hospice through our Care Team 6 initiative. And she is wonderful. She's a certified dementia practitioner and also works with the community to ensure that their residents, patients, and loved ones have the resources and care that they need while going through hospice. So we very much look forward to her insight and her knowledge to be able to present to you all.